we will cover brief intervention as step 2. So after you do your screening, we go into a brief intervention, and then Nurain will cover a referral to treatment. With the brief intervention, we'll go through some of the goals, what are the components, play a little video as a demonstration, and then we'll go into the third part, which is referral to treatment, and Nurain will take us through what a warm handoff approach is. So that's our goals for today. An hour goes so quickly when we're having fun. So I do want to tell the attendees that they are welcome to give us questions or put comments in the chat. We'll also throw up some polls for today. So that's our goals for today.
Thanks, Shahima. Sounds exciting. So before I hand over back to you and Nurain, I'd like to go over a few things to ensure our attendees have a smooth and seamless participation in today's event. Firstly, we've made provision for Spanish interpretation. This is available throughout the entire session. Kindly follow the details. They've been posted in the chat. In the chat window, just check, you'll find the link and the corresponding instructions if you'd want to access the Spanish interpretation of the webinar. Now, as Shahima has also mentioned, you feel free to submit questions live to our presenter. You can pose these questions by typing them into the questions pane of the webinar interface. You can also send these questions at the end of the session, but it'll be helpful if you just type them in as and when you have a question. Just type it into the chat window, and our presenters will attend to them as and when. A recording of the webinar will also be made available for you to watch on demand after the event, and a certification of participation will be emailed to you 24 hours after participating in the event. So over to you, Shahima and Nurain.
Thank you so much. And I just want to say welcome to Nurain. Last week we had Fergus online with us. So those who are rejoining, we have a new face. So welcome, Nurain. How are you doing?
Hi, Shahima. I'm good, thank you. It's just cooking and hot in Cape Town today.
Cape Town is showing us a nice summer's day. Okay, so we've got our plan for today. So I'm just going to jump right into it. And Nurain, you can just stop me if there's anything you'd like to add, or if there's anything that you're seeing in the questions or chat for me to address. But I'd just like to just remind our audience what this training is about. So it's screening, brief intervention, and referral to treatment. So last week, we actually went through what is the introduction of SBIRT, what does it stand for, what does it entail, and then we also went into the screening tool. So SBIRT, as a reminder, is screening, brief intervention, and a referral to treatment. Nurain, can you still see my screen? Is it still sharing?
Yeah, okay. It's all good.
It just disappeared somewhere into my screen. Let me just find it quickly.
No, it's all good. Okay, it's out of the slideshow mode. There we go.
So I'm not sure what's happening, but when I click unmute and then it just disappears. Quite sure if there's anything I can do. Let me just maybe screen share that. Sorry for the technical issues. Okay, can you see that now, Nurain?
Yeah, there we go. Correct.
Okay, cool, thank you. So, and then just a reminder that we went through the World Health Organization Assist screening tool, which was the alcohol, smoking, and substance involvement screening test, a really comprehensive tool. And as part of the Assist, there's also a brief intervention component. So today we'll unpack what that actually entails. And then that is just the URL and the QR code. So if you want to take a picture of that to access the tool, it is a web app-based tool. It's automated and you are welcome to use it anywhere in the world. You can use it as the practitioner or as a self-screening tool. Okay, so then just to recap on screening, we use a non-confrontational, non-judgmental approach when we do ask the questions to our patients or clients. We need to describe the purpose of why we are using a tool. We cannot just jump straight into asking questions because it's quite sensitive information. And we also need to emphasize the confidentiality around what you're going to do with this, with the information and the scoring, and to avoid stigmatizing language as well, to just be aware of that. The people who come to our services are quite vulnerable, and so we don't want to perpetuate the stigmatizing language and use it when we speak to them. Okay, and then just to ensure that we use the screening tool appropriately, and luckily for us, the web app assist is now automated, so we don't have to stress about calculating the screening and the scores ourselves. Okay, so now I'm going to shift over to the main topics for today, which is brief interventions and referral to treatment. And so step 2 of SBIRT, so you got SBIRT. We are now dealing with the BI, which is the brief intervention. So remember last week I said when we do SBIRT, you're going to screen, then you're going to get a score, and that score will give you an indication at which level of risk that your client is using at. So there are various screening tools, as I mentioned, Audit, DAS, DoIt, and the Assist. This is just a decision tree to assist us to know when to do a brief intervention and when to do a referral to treatment. And majority of people who score in the moderate to moderate risk level will be using or getting an intervention called a brief intervention. When people start using at higher risk, they will then need further assessment and a possible referral to treatment or detox, etc. So it's important to link the screening score to the recommended intervention. So what are the...
Can I jump in there?
Yeah.
I'm just reflecting on a conversation we had with some service providers last week around using the assist, but also around sort of engaging with SBIRT. And the question came in exactly at the point that you'd mentioned before, is that when you're scoring this, like, and you now have the score, like, then what am I supposed to do? And the expectation that people sometimes have is, when you say brief intervention, what does brief intervention mean, and how long is it going to take me, because I don't have time. There's all of those kind of challenges. And what I then had to explain is, like, this process is really simple, and using the assist, like using the web app assist actually makes it a lot more simple. But we tend to complicate it. And so I think, yeah, just that important part of, like, you know, it's the lower risk patients, the sort of lower and moderate risk patients, that you engage in that brief intervention, and that brief intervention doesn't have to be hours long. It's not that you have a whole treatment plan. Like, there's not a whole process that's involved in it. It's that part of how you just engage. But I think, as you mentioned before, and as you recapped as well, it's the part of engaging in a non sort of confrontational and a non-judgmental way that's going to make a difference as well. Yeah, sorry, I interrupted you.
No, perfect. Please jump in at any point.
You're muted.
I'm actually not. Can you hear me now? I think there's some gremlins in my system again.
Hi, Shahima, we can hear you.
I think we might have lost your audio.
So you can hear me, Quadro?
Yeah.
Okay. So I think that is important, because often we think as we need to have all these specialized skills to engage.
Shema, I'm not sure if it's just me, but I've lost your audio.
Can the rest of the people hear me?
Hi, Noreen. I think we can hear Shahima, so I think the connection might be from your end, so we'd reach out to you from the back end. Shahima, you could go on. Thank you.
Okay. So yeah, and often when we think about, as Noreen was saying, about this very brief intervention, it doesn't have to be a long plan. It's not long term. It's in that moment. So when you're doing the screening and the scoring, that you immediately start giving feedback. And I'll go into the components of what a brief intervention entails very shortly. But I think, yeah. I think that's a very important point. So just to remember, you get brief intervention and brief counseling or brief treatment, which is a little bit longer. Okay, let me just get back to the slide. So the goals of a brief intervention are to educate the patient on safe levels of substance use. And I must break that down because with drug use, there is actually no safe level. So this, when they say substance use, they're including tobacco, alcohol, and other drugs. And so with alcohol, there are safe levels. So you can educate that, for example, the WHO recommends for females that it is 7 standard drinks per week, and for males it's up to 14 standard drinks per week, with 1 per day or 2 per day, depending on male or female. And so that is the first goal or general goal for a brief intervention. The second goal is to increase the patient's awareness of the consequences of the substance use. So when we are trying to raise this awareness, it is using the principles of motivational interviewing skills. So we're not going to confront our patients and tell them straight up, this is the consequences of your substances, you better stop using. We want to use a different approach. And so we want to be collaborative, we want to be empathetic, we want to hear and understand what they are thinking and what they are feeling. So remaining empathetic is quite important. So, and then the third goal is to motivate the patient towards changing their substance use behavior. So gently just trying to understand what they think they can do to start using less or reducing the risk related to their substance use. And then the last goal is to assist them in making choices to reduce their use or the problems related to the using. And again, keeping this collaborative is key. We don't want to be prescribing what our clients or patients need to do. We want to keep it engaging. We want to keep it collaborative as a partnership, because at the end of the day, they are the experts of their own lives. We are just guiding them through their journey or through their process in making changes to their substance use or alcohol use. Nurain, is there anything else you'd like to add if you are still there? Because I can't actually see if you're still there.
Okay, no, I'm still here. I just had a little bit of an audio gremlin on my side. Yeah, I think the important point that you mentioned, I think, is the first point around educating the patient on safe levels of substance use. And I think, you know, the question always comes up of what do you mean by safe levels of substance use? Because there is no safe levels of substance use. So there's that part that comes up. But I think, yeah, that part of not engaging in ways that are, you know, you're there to raise patients' awareness. And you're there to highlight any consequences and those kind of things of substance use. I think the one challenge I often experience is that patients tend to want to get, want to say like very technical or very intellectual with like, okay, but when you say these are the consequences, can you tell me what impact it has on this part of my body and that part of my body? And I'm not medically trained, so often I don't have those answers. But it's that part of, you know, the main reason you're doing a brief intervention is to bring overall kind of like, these are the concerns, you know, what is it that we can do to kind of manage these concerns? So I think it's, you know, the third point around really motivating patients towards that change, that's really key. You wanting people to make changes because you don't want to have long-term issues in, you know, going forward into the future. Yeah.
Yeah, that's quite important as well. Okay, I'm gonna move on because I see time is ticking by. So besides the goals, and the goals are quite important, we now move on to why would we choose to do a brief intervention. And you've already touched on this, Nurain. Often our settings, especially in low resource settings, if you're going to an emergency center or a clinic or a hospital, the number of patients that we have to see, the benches are full. And so that's where people say, I don't have time to still do an intervention. Now you're asking me to screen for substance use on top of all the work that I'm already doing. But we're saying a brief intervention can take up to 5 minutes. It can take 2 minutes, it can take 3 minutes, just depending on which elements of the brief intervention you can focus on with your patient at that time. So it does save on time, and it's rather giving some intervention rather than nothing, and letting the patient just leave after screening with nothing to go with. So it's just important to do a brief using some of the components. It is It does prevent costs. So when we think of the progression of substance use disorder and the challenges that comes with it, the health challenges, the social challenges, the people stay out of work, absenteeism, all of those are compounding factors in the long term. And also the medical costs, so going for treatment, going for detox. So with SBIRT and a brief intervention, we're saying let's intervene as early as possible. Let's do something now before it gets worse, so we can avoid those costs. And also, you don't need like manuals, so the cost there as well, you're saving on that. You don't need lots of manuals that you need to print and go through. It's literally like a 5-minute training also, that you just go through the elements and use your counseling skills to do a brief intervention. And then, as we know, SBIRT is an evidence-based treatment approach, and so it is effective. It's globally researched. It's researched in high-income countries, low-income countries, and it does show that it is effective. Okay, so now I'm going to go into the various components of a brief intervention, because now it's going to sound just like a lot of concepts and information, but when I play the video in a short while, it'll give you an idea of what it entails and how one would do it. So it might look like a step-by-step approach, but it doesn't have to be like 1, 2, 3, 4, 5. You start with feedback, but it will evolve as the session evolves. So the first component is feedback. So once you do your screening, you will get a score, and the score will tell you what level of risk the person is using at low, moderate, or high risk. And so you want to provide individualized feedback to the client. So you want to say you scored 22, and this is putting you at high risk for various health and social issues if you continue using at this level. So you want to provide individualized feedback based on the screening scores. Then we would like to acknowledge that the client is responsible for their own journey and their own behavior. Again, like I said earlier, we're just here to be a guide. We want to guide them through this process. We can't take on all that responsibility. It's not up to us to force people to stop using or drinking alcohol. We can only guide them to the various processes in order for them to make choices to either reduce their use or to stop. But ultimately, the responsibility lies with the client. And again, Nurain, you can also maybe touch on this. Often us as healthcare workers, we feel like ethically, yes, we are responsible, and then we also feel like we have to get this person better on our terms. And then it puts a lot of stress and pressure on us as the healthcare worker. But ideally, we want to hand over the responsibility to the client. I'm just wondering what your thoughts are on that.
Yeah, definitely agree. I think that, you know, as healthcare practitioners, I know from my own experience, but I also see it like amongst colleagues, is that, you know, we feel like we've got to take the responsibility, and that we have to somehow like get into this aggro position of getting the patient to make changes. And it isn't really, it is about empowering the patient to take responsibility for their own lives. I think it's, you know, you effectively, you are drawing out what are the concerns if you carry on the way you're carrying on. And the responsibility is then up to you to make some of these shifts and some of these changes, that this isn't something that can just be done like for you. This is something you've got to do. And I think especially with substance use, because I think, you know, in sort of substance use dynamics, there's often this thing of, you know, the person using might be coming across as the victim and somebody else is the persecutor. There's often this dynamic that gets set up. And so you don't want to reinstate that dynamic as the healthcare practitioner. You are coming in with bits of information that you know, but as you mentioned earlier on, is that at the end of the day, the patient is the expert on their life. And they've also got to come up with whatever their goals are around, you know, what do they see as them taking responsibility. We may have something in mind. They may have a different picture in mind. So it also means we've got to be open-minded to that too.
And also, yeah, and keeping the discussion going between you and your client instead of just you prescribing the treatment approach. So thank you for that. And then, thanks. And then the third part or component of a brief intervention is advice. And this is advice So using motivational interviewing principles, when we give advice, we often first check in with the client. So asking for permission to check if they are ready to also accept the advice and information. So once we ask permission, can we discuss some of the information around the harms related to substance use, and then also get ideas on what they think the harms are that are related to their substance use. So advice needs to be factual, it needs to be clear, it needs to be based in what is really happening, not making up your own stuff. So if you don't know something, don't give advice based on just personal experience, like saying, oh, you know what, my friend did so and so, I think you should do this. We try to stick with factual information, research-based, and provide it in a non-judgmental way as well. Okay, so that's a third component, is providing clear advice.
Shema, I'm just jumping in here as
yeah?
well. I think, you know, with the advice part, I think my concern always is like you're saying, like it's providing factual information, because I think my worst fear is if a patient comes to me and says, oh, you know, I told my friend that you said do X, Y, Z, because your friend did X, Y, Z and it worked for your friend. So I always fear being told something like that. So it's that way of how we actually advising, that we're giving factually based things, and it's not coming from like finger waggy kind of like I'm pointing my finger and that's what you've got to do sort of thing. Yeah.
Exactly. Okay, and then we're going to move on to the fourth component, which is the menu of options. And here again, it's looking at alternatives for change. So what is possible for the client? And again, asking them, what do you know is available within your community? What is it that you can go to? What is it that you can do as a, like, instead of drinking and going to parties, what are the alternatives to that, and what are the resources within your community that is attainable for you? So discussing that and keeping it as a conversation again, and you're going to hear me say this over and over, keep it collaborative, discuss it, and it's a partnership between you and your client, because again, you don't want to be saying, I think you should be swimming 3 times a week at the gym instead of going to hang out with your friends and drinking. That's very prescriptive, and it's assuming that the person can go swimming, that the person knows how to swim, that they have access to a swimming pool. And we know in our setting, which is a low resource setting, that maybe those options are not available. And so keeping that discussion open and realistic, instead of just being prescriptive and saying, I think you should do this, that, and this, and then you will stay away from your drugs and your drinking. So providing that menu of options, but having that as a discussion and getting ideas from the client is important. So you can already see from all of these components of a brief intervention, it's not a one-way street with me as the expert and my patient or client is just receiving this information. It's a conversation. It's an intervention. It's, let's look at the risks. Let's look at your responsibility, your role in this. Let's look at what you think you are capable of achieving or going to do as alternatives for change, and so forth. And then the last two, empathy and self-efficacy. Having empathy is vital. We have to really understand our clients. We need to understand where they're coming from. We have to be reflective. We have to be genuine. And so with that, we also have to have optimism. We have to have belief in our clients so that they can also gain the confidence that they can make changes and that they can achieve some behavior that behavior changes that's towards reducing their harms, etc. So those are the components. If there are any questions, please do put it in the chat. If anything isn't clear, we can answer that. So at this point now, I'm going to, let me just stop screen sharing. I'm going to play a little role play to demonstrate what a brief intervention entails. So just a little bit of background, it's a role play. We're just acting again in this video. And the person was screened using a screening tool, and the session will start by discussing the score and basically doing a brief intervention. So I hope that this will be useful to give you a little bit of an idea of how a brief intervention can be done in like under 5 minutes. So let's play the video, and then you're welcome to put comments in the chat, also your thoughts on that engagement and what you're seeing in that. Okay, let's play the video.
Lula, thank you so much for all that information whilst we've been completing the due. I recognize that it's not easy to speak about all these difficult parts in your life. What we can see is that your total is 22. That translates to a moderate to high level of risky methamphetamine use and corresponds with using 2 to 3 times per week and 3 to 4 times per day. This puts you at risk of physical and mental health challenges.
Okay, I wasn't aware that like my using would cause such concerns. I mean, I use just because I need to get through my job and to get through my day, and moving from shelter to shelter or place to place is like what I need to do in order to survive. And I just came here because I've been feeling like a bit low.
Okay. What you do with your methamphetamine use is really up to you. I'm here to understand you and maybe think about ways in which you can move forward.
Okay. Do you think you can tell me what it means that I'm at harmful risk?
That's a really good question, Lula. Harmful risk means that you're more susceptible to physiological problems, for example, dramatic loss of weight, sleep difficulties, and psychological problems, for example, being susceptible to experiencing depressive episodes and episodes of psychotic illness.
Okay, I have lost actually quite a lot of weight, and my mother always used to say when she used to see me that I've just become like skin and bones. I mean, are there any other things that could happen to me that I'm at risk for?
Sounds like your mother was really concerned about your drug use.
Yeah, when she was alive, she really begged me to stop using drugs and also to stop with the sex work. She wasn't happy with the choices that I was making, but I needed to just do what I needed to do.
It must be really challenging not having your mother around, but still knowing that you're using methamphetamine to survive.
Yeah, I do miss her, and I feel guilty for using and that sort of thing. And she was really angry at me because I was using and also because of the sex work. But you know, I have to do what I need to do to survive. But I'm also wondering what else am I doing that's putting me at risk?
Okay, it really sounds like you have some sort of awareness of the consequences of your methamphetamine use. If you decide, we can spend some time thinking about addressing some of the issues that you're experiencing, namely maybe the depression that you're encountering.
I'm probably depressed already. I haven't really been feeling myself much at all lately. I had this one experience where I used quite a lot, and then I was sexually assaulted as a result when I was at work. But it's probably just a hazard of the work that I do.
I'm really sorry to hear that. No one deserves to be taken advantage of in that way.
I guess I just have myself to blame. I used too much on that night.
Using too much doesn't really condone the way in which you were treated. I'm really sorry to hear that. It seems your methamphetamine use has really put you in some risky situations thus far.
Yeah, look, I can't live like this much longer, but what else am I supposed to do? I don't really have any other qualifications. I've just got my matric, and that's it. So I don't really have anything else to fall back onto.
It seems like you've really been thinking about some of the ways in which methamphetamine has impacted your life. I wonder if we can spend some time thinking about ways in which we can address and move forward, even if we develop a list of some sorts.
Yeah, that would really be helpful. What are the options that you can help me with? I just want to feel better.
So perhaps we can think about ways that can lower your risk. Have you tried anything in the past?
Yeah, I've tried this thing where I use just once a day, and then what I was thinking is maybe if I can just use once to get through the day, and then I can just use again only the next day.
That sounds like a really good strategy, Lula. It's showing that you're really thinking about using less. Are there any other ways that you can think of lowering your risk?
I don't know, maybe if I find a different job, or I find something else that I can do, then I don't need to use the TIC every day.
Okay, so you're thinking of using less and also making potentially a change in your work. Maybe we can have a look at your CV and think about bolstering it.
Yeah, that would be helpful, and maybe in that way I can use less stick, but also then like feel less depressed. Is that something that you can help me with?
Yes, myself and the centre can help you exactly with that. At the centre, we also can continue with your therapy sessions, and we can maybe even thinking of joining you into a therapy or self-help group. Does that sound like something you'd be interested in?
Yeah, I can do that for now.
Okay, great. Then we'll see you next week.
Okay. Some reflections, Narayan. I'm such a good actor. You and Fergus.
It was terrible. I always think these are like, yeah, definitely not Oscar-winning performances. Yeah, I think for me, what comes to mind with that, that brief intervention is that it was brief. There wasn't anything that was long. There wasn't anything that was drawn out. And then just how easy it is to incorporate sort of also bits of motivational interviewing, that you're not engaging, like I said earlier on, you're not engaging with the patient in like a finger wagging way where you're pointing at them saying, oh, you're using this is what you're doing, and you're doing sex work, like, oh my word, like there's none of that comes through. It's that part of treating the patient, where they are at. And I think then looking at, what are their goals and harnessing on their goals, because there's the patient kind of saying, okay, look, this is what I'm at risk of. Maybe I could change my job. Maybe I could start using less. These are the ideas that I've got. And almost sort of maximizing those little nuggets.
Dana, you still there? I think we lost Nurain there for a moment. Okay. There's load shedding in South Africa, which means at times we are 2 to 4 hours without power, and it affects our network. So apologies for any of these technical glitches. But yeah, I'm also wondering if there's any, if people can put their thoughts in the chat around the video, and we can read some of that a little bit later. But yeah, we'll get Nurain back on. But I like what she's saying. It was the approach that the counselor took was non-judgmental, didn't focus on things that didn't really matter or doesn't really affect the overall goal of a brief intervention. It was a conversation. What can I do? What is out there? So when a client does ask us for recommendations, we can share the recommendations, but at the end of the day, it's still ultimately their decision what they are capable or able to do. So yeah, I think that the briefness came through very well, and all the components that I just spoke about also came through. So there was the feedback, there was the menu of options, some advice giving, and there was definitely empathy and building on the client's own autonomy and responsibility. Okay. So now that is brief interventions. I want to just check who's still with us. I'm going to throw a couple of polls up. Quite if we can maybe just put up the first poll. And these questions are just asking if it's a statement and it's either true or false, or there's an option to choose. So let's just do a poll. Oh, Nurain, you're back. We're just going to do some polls, and then no worries. We can you can reflect a little bit further on if you still want to add some more about the video after 1 or 2 polls. Is that okay? I think Nurain is frozen. Okay. Okay, so let's quite if we can put the first question up, a poll. So the first question is, brief interventions is not, and not is highlighted there, an evidence-based intervention approach. Can you select whether it is true or false? Okay, Nurain, I'm seeing people are already voting. And majority thus far is saying that it's false. But let's give it another few seconds.
Give it a few seconds.
Yeah.
Almost feels like a drum roll is needed.
Yeah. Okay. Let's give it another 10 seconds. It's about, let's get to 50% of the votes. It's still coming in quite quickly, so yeah. Whenever you throw a not into a statement, you always have to think twice. So the statement is brief interventions is not an evidence-based intervention approach. Okay, I think we can cap it there. We're at see the votes are still coming in. Okay, we're just collecting the responses. So is it true or is it false? Okay, let's end that poll over there. Okay, so from the votes, Nurain, 83% of people said that it's false, that the statement is false, and 17% said the statement is true. So the correct answer is that it is false because a brief intervention is an evidence-based approach. So you see some of the language when you throw in that not, and then it becomes confusing. So yeah, brief intervention, which falls part of SBIRT, is an evidence-based intervention approach. Okay, let's see the next question. Let's throw up the next poll, and it's around frame. Okay, so the next question or poll is, frames is the components for a brief intervention. Is this true or is this false? So I'm doing a bit of testing here to see who listened to us. Okay, we'll maybe just give it a minute because there's actually quite a lot of people online today. So we'll just give them some time to choose. Now, I think after this poll, we'll just move over onto referral to treatment. Okay, so let's give it another 10 seconds and then we'll stop it over there. Please, if you can just vote, frames is the components for brief intervention. Is that true? Is that false? Let's get the votes in. And there's no not in here, so it's a little bit easier. Okay, I think we can maybe stop the poll over there. Let's have a look at the responses. Okay, so from the votes, Nurain, 20% said that that is false and 80% said that that is true. So if you remember, we had the slide up with the little frame and all the components, and frames was definitely the components of a brief intervention. So remember, the F was for feedback, the R was for responsibility, the A was for advice, the M was for menu of options, E was for empathy, and S is self-efficacy. I saw somebody putting there in the chat a question that they forgot. Sorry, no worries. Okay, so that's just some fun polls to check that you guys were paying attention. Okay, Nurain, that's the end for brief interventions from my side. I'm going to screen share the referral to treatment for you, if that's okay. Are you there? So I think Nurain is having lots of connectivity issues. So I will just jump ahead and start the referral to treatment, and she can just hop on. Let me just continue. Okay. So remember now we did step 1, which is the screening. We used the WHO Assist web app tool. I demonstrated that. Then we just watched the video on step 2, which is brief interventions. And now we're moving on to step 3. And step 3 is referral to treatment. So I think we lost Nurain, but when she comes back, then she can just hop back on. So let me just get to my slide. So with referral to treatment, there are a couple of goals and steps that one needs to take. Often, yeah, referral to treatment sounds very simple, but with the SBIRT model, we want to encourage a warm handoff approach. And a warm handoff approach are the following. It is reducing barriers and building bridges between you and the referral organization, as well as including your client within that referral process. So firstly, we want to discuss and describe what is available treatment options with the patient. Nurain, are you there?
I am back. Apologies. I am having issues with my internet connection because of the power cuts, and so my connection keeps dropping.
That's life, it happens, don't worry. If you want to continue, I just introduced it, so you're welcome to take over, and I can just you can just tell me when to change slides.
Okay, where did you pause, or where did you stop?
I was at step number 1, describing and looking at the treatment options, discuss and describe available treatment options with clients. Oh, I think, okay, this is not working today for Nurain. Oh, I'm so sorry, everybody, about that. I do apologize. I think I'll just continue. And then so basically discussing and describing. So firstly, you first need to understand when somebody gets referred to treatment, they are scoring moderate to high risk. Only 5% of the population of people who use alcohol and substance, who have a substance use disorder, will need specialized treatment. So those who score low to moderate risk might not need a referral. They might just need a brief intervention or brief counseling session here and there, just to avoid them from escalating their use. So that's one thing to remember, that only 5% of the people who use substances will score at high risk for substance use disorder. And so it's important then to discuss what are the treatment options, because some people will need a detox program, some will need inpatient programs, some will need outpatient programs. And so it's important to discuss the various options with the client, and then also to find out what do they know is available within their communities. Step 2 is to ask permission to facilitate the referral, because not everybody is going to be happy with the referral. Some of them might not want to accept that they've got that they're using at high risk, and so they're not ready at that moment to take on a referral. And so it's important to firstly ask permission, and then also just again to remind them about the confidentiality of the processes and the limitations of that as well. So if somebody is using at high risk and they are putting themselves in harm's way or putting others in harm's way, then the process might be slightly different, because you might have to start an involuntary process. And so we just have to bear in mind all the various options that might come with that, or scenarios that might come with that. And so then step 3 is to first, it depends on your organization and where you are based. So some organizations are able to refer within their organization, and so it's important then to keep those pathways open within your organization and have the list of resources within your organization. So whilst people are going to need treatment for their substance use disorder, they may need other services as well, like counseling, family counseling, trauma counseling, psychiatric assistance, etc. So keep the communication open and clear between you, the person you're referring to, as well as your client. And then with step 4, with referring outside of your organization, it does take a bit of coordinating. And this is more important with a warm handoff approach. You don't want to be writing a referral letter and then telling the client, okay, go and see Mr. Stevens at X organization. The person's probably most likely not going to go. And so when you are busy making this referral, you could, for example, ask your client if you could facilitate it. So call Mr. Stevens ahead of time while the client is still sitting in your office, in order to kind of give that warm handoff approach. So that's what I mean by warm handoff approach. It's being part of the process to the referral. I know often when in my kid's life, when they tell you to go see a specialist, but there's no warm handoff approach. It's literally, this is the issue, here's the letter, go see doctor so and so, and you can make the appointment and go see them. That envelope with the letter remains sealed for I don't know how long, until the problem probably arises again, and then I'm like, okay, I have to take this, I have to go to the specialist. But I would appreciate a warm handoff approach to referral to treatment. So just to be empathetic and to assist where possible. So again, in South Africa, in low resource places, we might not be able to offer some of these services like transport and getting the client to the referral agent, but at least attempt to coordinate it and keep it quite organized with the patient. Nurain, are you there? I'm not sure if Nurain is here.
I am back. Sincerest apologies. My reception is really bad, and I think I've now received.
Okay, I think yes. Nurain, sorry, I think there's still an issue with your network, so I think I'll just continue. And so the sound is like, it sounds like you're robotic, and I don't want it to sound robotic. I'm sorry.
Actually, an issue.
Yeah, so let's
cell tower. That's why.
Okay, I'm gonna continue. You can just listen in, and then maybe if you can just check the questions and chat in the meantime, and then if your internet stabilizes, we'll bring you back on. Okay, so this is just again a summary. Like I said earlier, only 5% of patients that is screened will require that further assessment and evaluation, and then a referral to treatment or detox. And detox is especially important for people who are using at severe risk for an alcohol use disorder, as well as your heroin, opioid use disorders. So yeah, so like I said, also your client might also need other services. So other services includes legal, some other medical conditions associated with a substance use. So yeah, so you just have to always ensure that you've got a community or a list of resources. And what I also would encourage is, when you're doing your referral, you know the person that you're referring to. So you've spoken to this person, you've met this person, just so that you can keep communication open and that they can refer to you as well if need be. So building those bridges, as mentioned. Okay, so when we're doing the referral, we want to reduce barriers, we want to maintain that list, we want to ensure that that relationship between organizations is a good one. And also another important thing is when referring to an organization, ensure that they are also a valid organization. So they are registered with various boards. In South Africa, we have to be registered with social development, for example, that they're using evidence-based approaches, because often there are organizations that are not up to standard. And so we want to ensure that your referral network is a group of organizations that are keeping up to standard with evidence-based approaches. Okay, so this is just a map that for you to go back and just draw on what you know is in your community, and to ensure that you can kind of map out for yourself when you are working with patients where to send them to, and have your various facilities, so your medical, legal, family counseling, trauma counseling. So just for you to think, this is just an activity for you to go back and think about your resource list for within your communities. Okay, finally, if a person does not want to be referred, and we have many patients or clients that will say, no, I am not ready to be referred. At this point, we have to accept and respect the client's decision. So here we can just encourage a follow-up session, keep the door open, tell them that you are there for them. They can come make a follow-up appointment with you if they're comfortable. And when they come and see you, you can inquire about their use again, check in if it's escalated or not, maybe talk about some of their goals. And hopefully this will foster some motivation to take on a referral in the future. Okay, so my last slide is just a little funny cartoon character. You can read it, you can see on the left. Now for your shoulder problem, I'm going to write a referral for you to see a specialist. And then the client says, okay, cool. And the doctor says, so just look up an orthopedic specialist in your area, make an appointment and show them this. And the client says, sounds good. And then he thinks to himself, I'm never going to do this. And this is exactly what I was referring to, even in my personal life. I often just get the letter, never follow through on that. Okay, so in summary, we use this assist to screen. We review the scores and check the level of risk. We provide the recommended intervention. If it's a brief intervention, based on the score, we do a brief intervention. If it's high risk or level of risk, we refer to treatment and further assessment. So I'm going to stop over there, and then I'm going to put 1 or 2 more polls up just to check if people understood me. I just want to close that. I don't know what happened to my video. Okay, can we throw up a poll? Can we look at the question around referral to treatment? And then it has 3 options. So referral to treatment, and then it will say is not part of SBIRT, or referral to treatment recommends using a home handoff approach, or is referral to treatment just send a letter with the client. So let's see. So referral to treatment, which one is most appropriate? Is referral to treatment not part of SBIRT? Does referral to treatment recommend using a home handoff approach? Or does it say just send a letter with the client to the specialist? Okay, I see the votes coming in. Let's see what happens. Okay. So I'm seeing the votes coming in, and it looks like a majority of people are selecting the one, but I'm not going to say which one just yet. So I'm going to give you another couple of seconds, and then see what you guys said. Okay, let's please just select one if you're not sure. Okay, let's stop the poll over there. So majority of the people, 87% of the people said that the referral to treatment recommends using a whole Mandorf approach, and that is correct. As explained, you want to build bridges, you want to make your client feel like you are walking this journey with them, and that they're not just left on their own with the letter to go and see the specialist or go to an organization. Okay. So then we've got 2 more minutes left. And Nurain, I'm sorry to hear that your internet is still quite problematic, but you are there, I can see you. But if you can't speak, it's okay. Thank you, Cora, for putting up the polls. I think we're running out of time, so I just want to check if there's any questions that we can answer for you guys. I just need to get quickly to the questions.
Okay.
Hi.
Let me help you out with the questions.
Yeah.
Yeah, so we have the first question, which is, with the assist, are we able to give each opioid its own score, like heroin and opium?
Yes, so in the assist, there is a category for the opioids, but if, for example, you aren't sure if it actually fits into that category, you can also use the other category. So in South Africa, for example, they use Niope, which is a mixture of things, but heroin is in there as well. So you can use the other category to screen if you're not sure where it fits. So definitely.
Okay. We also have another question. How could we apply the BI with the same client who comes to the second session with a counselor?
That's a very good question. So it does depend, I guess. I mean, you need lots more context to that question. But if we're talking about somebody that didn't want a referral to treatment, then you'll check in with trying to raise awareness between the substance use and the consequences. You will try to motivate them towards making some changes, and parts of that changes could be taking on the referral to treatment. So the answer there, it can go like all over, but basically you can provide feedback from the previous session also, and just remind them that was your score. I'm wondering what you think about that now. How do you think that has impacted on your life? So it's just raising that awareness and keeping the conversation open without judgment.
Okay. Also, what is a screening tool that could be used for adolescents or youth?
For adolescents and youth, there are many tools. There's the Craft, there's the DAS-10, there's also the ISSUP. So that web app tool that I shared with everybody, if you put in the age that's under 18, it actually takes you to the ISSUP, which is for under 18s. And it actually screens from age 10 till 17, but you need to use a provider. You need a therapist to do the screening with the young ones, but the ISSUP is for adolescents.
Okay. This is a comment, and it seems like a delicate balance between warm handoff approach and giving responsibility for care to the client.
Exactly. You want them to take responsibility, but you also don't want them feeling like you just threw them into the deep end and like they're on their own. So perfectly said, striking that balance between giving responsibility and then also helping to facilitate it by being alongside with them. And the discussions around the types of treatment and the menu of options, that keeps them part of the responsibility, and also giving them the autonomy to choose which one might be better suited for them. So great comment.
Yeah. Okay, so we have another one here. How reliable is the SBIRT when translated into local language? It's in English, and most of my clients at my facility do not have a good command of the English language. Is there any evidence on this? So
That's a good question. From what I know, motivational interviewing is culturally appropriate. You obviously have to translate the skills or the way that you're doing your counseling into your own language. But the counseling skills is genetic, in my opinion, across cultures. It's then up to the language to get the appropriate words in order to make that conversation and to keep it. So empathy, what is empathy in a different language? And empathy is actually a way of being. And a lot of SBIRT is that engagement. So it's being non-judgmental, it's being non-confrontational. So in my opinion, but I can check what the research shows. I don't know if Narain knows, she can type to me if she knows of any papers that looked at translations. But in my opinion, it should be able to be used across cultures.
as you're saying, not a direct translation, but maybe it should be adapted to the culture.
Yeah. And this, yeah, sorry, if I can just add, the screening tool, the ISSUP, for example, was found culturally appropriate, and I'm thinking that includes language in like 8 countries globally. So it has been shown to be culturally appropriate.
Okay, thank you. The next one is, for the advice, you mentioned that it should be evidence-based. Is there any literature or manual for the healthcare service provider to provide evidence-based suggestions?
So if we look at the ISSUP tool itself, it has the screening component, then it actually already has a built-in brief intervention component. So all the facts around the various substances and the harms related to it, you can literally read it from the tool. So if somebody's using, let's say, methamphetamine, if they're using at moderate risk, it will actually pull up that you're using at moderate risk for methamphetamine, and if you continue your use, these are the risks for that substance, and it will touch on physical risks, medical, psychological, social, etc. So it's built into the tool already.
Okay, I don't think this is a question, it's more of a comment, but let me just read it out. In substance use service provision, care providers are trained to allow patients to take decisions to stop their substance use problems. Advising patients on the risks associated with substance use should not be the work of the service providers. Instead, providers should provide insights for patients to take appropriate decisions. I don't know if you got that. I was a little bit confused.
There's many layers to that comment / thought. So I think the responsibility for a patient or a client lies within the client, but facilitated by the healthcare worker. I'm going to use healthcare worker because I was getting confused there with provider and service user. So the healthcare worker, like I said, has ethical considerations, confidentiality, things that they need to consider. They are the subject experts, as in knowledge around substance use and the risks and harms, etc. However, the client is the expert of their own life. So with SBIRT, and especially with brief interventions, you want to understand from the client, what do they know are the risks, or what are they seeing are the risks with their current use. So the responsibility is twofold. It's the client and the healthcare worker, but ultimately, I can't force somebody into treatment. It's their responsibility, their choice, and we have to accept and respect that.
Yeah.
Okay.
I think someone also wants a confirmation. For moderate to high risk, what does BT mean? Is it the brief therapy?
Yeah. So when it's going towards high risk, you're doing a brief intervention as the minimum, but then then you start going into the longer sessions if you can, depending on the setting. Some organizations can only screen and refer. So depending on who's doing the screening, but if, for example, I'm a registered counselor, I can go into a brief therapy session if the time allows, because it's going towards that higher risk. And so we need to monitor that person in those sessions and check that if they start reducing use in those therapeutic sessions. If not, if they continue and it escalates, then a referral to treatment would be needed.
Okay. Okay, so Jemima is also commending the presentation as a good presentation. However, I did not catch due to unstable network. Jemima, a copy of the video would be on the website, and after 24 hours, you can access it on the ISSUP website. So a link can be shared with you to access that. And I think we can, okay, so does it mean Assess tool is only used for underage, that is 18 years or below?
No, so when you play with the tool, the web app tool, the first question is going to ask you for a date of birth. So if you are older 18, it takes you to the questions directly that is for over 18s. If you are 16, for example, it's going to take you to those questions that are adapted to children or adolescents. So the questions are different, but it's basically the same tool. It's all in one. So it's for all ages, 10 till, I don't know, 99, 100.
I guess I can take the last question here. Could you clarify a bit more about the limitations of the BI application?
Limitations of a brief intervention. So that's a good question. I never thought of limitations because I always just advocate for using it, no matter what the situation is. So even if somebody's using at high risk, I would still start with the brief intervention, just to start engaging the client and getting them comfortable to maybe share more. Limitations, I guess, if somebody is using at severe risk and they maybe drug-induced psychosis, they will need to get stabilized, and so you can't intervene at all with somebody that's not able to respond appropriately. So I don't really think there's a limitation that is even a limitation, because I think that will actually apply to any treatment approach. If somebody's not able to communicate, you can't do any treatment with them. You need to first stabilize them medically. So, but I can go and research and check if there's any limitations in any of the research.
Okay, thank you, Shahima. I do not. Do you have any closing comments?
I do not. I just wanted to say thank you to the attendees for engaging us on the polls. I know it can be like feeling like an exam, like, oh, they're putting me on the spot. I didn't hear that, or I didn't catch that. But it's just to check in that people are still there and just reinforcing some of the content. So I am just wanting to appreciate that and for engaging us and for the questions as well. And Nurain, I know you probably can't speak, but so I'm speaking on behalf of myself and Nurain, to just thank ISSUP team as well for collaborating with us on this webinar series, and can't believe the second part is done. So that's all from my side, and thank you from the South Africa ITTC as well.
Okay, thank you from our side to Shahima and Nurain. It was really great to have you on here. We are looking forward to more webinars as such in collaboration with the ITTC and the University of Cape Town. So for our attendees, this concludes the two-part series on the SBIRT. And as a reminder, you receive a follow-up email within 24 to 48 hours with your certificates of participation and a link to view a recording of today's webinar. So on behalf of ISSUP, ITTC, Nurain, Shahima, thank you for joining us today, and enjoy the rest of your day.
Thank you. Bye.